By the way, we've got Robert Dozier, Executive Director of Mississippi Independent Pharmacies Association. Hey, Robert.
Good morning, Gerard. How are you today?
Good to see you.
Good.
Just wanted to interject this in from the last segment. I did a little searching during the break. It is first-generation home buyers. So.
I mean, to me, Gerard, that seems like it's hard to prove. How do you prove that?
Well, since when has that ever mattered when we make these giveaway corporate programs, government giveaway programs? We don't care about that. Just sign up. Here's your check. Speaking of, Robert, I believe it was the Inflation Reduction Act.
Correct.
That included provisions in it that required, essentially, the way it's described as Medicare would be required to negotiate prices with the drug makers that are covered by the Medicare program. Part D is really considered the primary coverage vehicle under the Medicaid program. That's the prescription drugs. That was enacted under George W. Bush, as I recall.
Medicare Part D was.
Part D,
that's correct.
Right. That is different from A and B. One of those is hospitalization. One of those is primary care. I don't remember. That was kind of the basic Medicare for forever, right? And then
that's right.
C is Medicare Advantage, I believe.
I think you're right. Yeah. But Medicare Part D is strictly prescription drugs.
Right. So what looks like is happening, however, so even though the Biden administration has taken a victory lap about how this is driving the price of certain drugs now. Insulin's one they point to probably the most, capping it. It looks like the Medicare is saying, okay, we're going to have to raise insurance for standard Medicare, the other parts, A and B, which also provides some drug coverage as well, as I understand.
Yeah.
Unravel this for us.
Yeah, well, I don't know if we have enough time in the day. I don't think they need to be doing a quick victory lap just yet.
Okay.
You know, they've identified 10 drugs. These 10 drugs they're focused on heart disease, diabetes, cancer, kidney disease, and blood clots. And they're claiming that these 10 drugs cost 1/5 of the total cost. And I could believe that, especially when you start talking about
what do you mean
diabetes.
Cost 1/5 of the total cost? That the production cost is 1/5 of what they're selling it for?
1/5 of the cost to the Medicare Part D program.
I see.
To the overall prescription drug cost for the program.
Okay.
So and I can believe that, especially when you start talking about these high dollar insulins with diabetes and everything.
Yeah.
But here's the deal: they can go out there and they can claim they're going to negotiate these deals with the drug manufacturers and hopefully pass on these savings to the patients.
Right.
All right. How's it going to work? Because you still have to go to the pharmacy to get the prescription as a patient. The pharmacist still needs to be able to make an adequate reimbursement. But here's the one part that they're not talking about. It's the Medicare Part D plans. AKA the pharmacy benefit managers. They are the ones that are going to set the preferred drug list, the drug formularies. Well, what if they don't put those drugs on that formulary for those seniors? And in the IRA, the Inflation Reduction Act and everything, there's no, I guess, tool in there that would regulate these Medicare Part D plans to make them put these cost-saving drugs on these preferred drug list. So,
okay.
you know they've claimed they've gone out here and they've negotiated these prices, which is good and everything, because the seniors do need lower prescription drug costs. But what you just said, they might turn right around and raise the cost on A, B, C, and everything else out here.
Yeah. So it's almost like it feels like you're plugging a dike here, right? So you put your finger in one hole and there's another one.
Or you're squeezing a balloon, you squeeze it and then it pops out somewhere else.
Is this just another example of government meddling here that always seems to produce these unintended consequences? It's great intentions, I guess you could say, in trying to cap and limit the cost of drugs, in particular to seniors. But the other thing, Robert, you're probably aware of, is that there's an announcement of Medicare premiums going up next year as well.
And exactly. And we have to do something to help the seniors out there. It's just like we have to do something to help the individuals in the commercial insurance market as well.
Sure.
Healthcare is getting outrageous, and at the end of the day, it's not the provider, the doctor or the dentist or the pharmacist or even the hospital that's making all the money. It's the insurance companies and the pharmacy benefit managers. And but we have to do something. Now, one thing, Gerard, is you start looking at the dates of when all of this is lining up. Well, these 10 drugs that they've supposedly negotiated, they don't go into effect until 2026.
Oh.
And so we're looking at that. Could that be maybe politics at its best? Because what are we doing right now? We have this is the day for one of our political parties' convention kickoff date.
Okay.
And so we're in the middle of a presidential election right now.
Yep. Well, you know that you're probably aware of this. The healthcare economy, the HCE as it is called, it's about $4.6 trillion in a GDP in a country with a GDP of roughly 24. It seems like it's been 1/6, fairly consistently going back to even the Obama era. I remember that coming up all the time, 1/6 of the American economy, 1/6 because of the Affordable Care Act was, of course, negotiated during that time period. And I do wonder. I've done some research on that, Robert, honestly, and the top 5 insurers that, in terms of size and number of people covered, account for about 85% of the commercial coverage in this country. United Healthcare, by far, the biggest. I don't remember the others. Cigna, Anthem, the other ones in there. Aetna, I think, maybe. But I went and researched their net profit. So their total aggregate net profit put together is about $45 billion. It's 1% of the total healthcare economy. So I'm not trying to be argumentative. I'm just saying, well, gee, if they made 0%, that's a 1%, and they plowed that back into reducing premiums, that'd be 1% reduction in premiums. Heck, the premiums go up rather consistently year after year. It just seems like it's a bad business overall. I'm talking about the whole healthcare business. I'm not sure who's making all the money because I hear everybody I talk to say they point to everybody else. They're all making all the money. I'm not sure, honestly. And it's just, I looked up Pfizer. Pfizer is the largest pharmaceutical company, according to my research, in the country. And they made $2.1 billion last year. Mm-hmm. That's 0.5% of the total healthcare economy. So if they made 0, that's 0.5%. I don't know who the heck's making all the money. I don't know if anybody's making any money in the industry.
Well, I just me speaking personally, I would take that 0.5% over maybe 10% what an independent pharmacist is making.
I got you. Sure.
If they're making 10%, in which I would.
Yeah, I get you.
That's
unlikely.
We're talking huge numbers here, and we're talking, a system that we've got to really sit down and have honest conversation right here, because at the end of the day, yes, we want businesses to make money. We want a free market. We want free enterprise. We want providers to be able to be reimbursed, adequate reimbursements to where they can stay there and treat their patients.
Yeah.
But the ultimate goal is for the patient to receive the benefit of care that they need and deserve, and not have to choose between, am I going to pay for groceries this week or am I going to pay for my prescription drugs this week?
I get it. And so another challenge, of course, that's just reality is the good news that the drug makers keep inventing new drugs that we benefit from. Bad news is they all cost money and we want them. That's true. So you could write an insurance policy today, based on what you know today, and then all of a sudden some new drug gets introduced and your doctor says, yeah, this would help you and prescribes it for you. Well, they're not expecting that. That's a whole new cost they got to deal with. They'll catch you next year. If you can stay around, we keep on talking about this.
Sure.
We got Robert Dozier, the Executive Director of the Mississippi Independent Pharmacies Association, coming right back in the Element Wealth Studio. We're back with you in the Element Well studio. We're chatting with Robert Dozier, Executive Director of the Mississippi Independent Pharmacies Association. So there's no doubt that the healthcare industry in general is very complex when you think about all the various players in it. And it's as we said, a $4.5 trillion industry. I think maybe on aggregate the largest overall in the country, certainly as a percentage of GDP. But further complicating the healthcare industry are the pharmacy benefit managers. And you and I have talked about that before. I challenge folks that are tuned in, go out and look that up. Use your favorite search tool. I use Google. And then click on the images selection at the top menu selection and see all the various flowcharts that depict the relationship of the PBMs to the pharmaceutical makers, to the physicians, to the hospitals, to the insurance companies. It'll hurt your head. I don't think anybody could explain it, honestly. I don't even know if the people who drew the charts could explain it. That further complicates things, does it not? There's kind of a layer that is kind of hidden.
Exactly, and it's like I was saying earlier that the government can negotiate these drug prices, but we don't know if it's actually going to get to the prescription counter for the patient, because the pharmacy benefit managers, they are the ones that set the preferred drug limits or list or the drug formularies. Mm-hmm. So they go and they create these lists by going to the manufacturer, the drug manufacturer, and getting this rebate money back. And it's kind of a pay-to-play deal, almost a legalized extortion to some degree. And so the drug manufacturer, they have to pay the rebate to get their drug on the list, and so that's how it happens. And what happens with that is, think of it like a kid that works at a grocery store. Well, if minimum wage goes up for that employee, that high school kid, well, what's going to happen is then the price of eggs and milk and bread's going to go up at that grocery store to offset the increase of that high minimum wage. And so that's what the drug manufacturers are doing. They're having to pay this rebate, but then they're steadily going up year to year on their list price for the drug.
Yeah.
And that's all being passed down to the patient at the pharmacy counter. And then you have the one-sided negotiations between the PBM and the pharmacies, and there's no negotiating. Like I said, it's one-sided, and it's a take-it-or-leave-it contract. And a lot of times these pharmacies are out here filling prescriptions below their cost, their acquisition cost, and they're hoping that they have more winners than losers, but it's getting really tight out there. Take a look at the store closures of Walgreens. Walgreens is announcing they're going to, I can't remember if it's 2,000 or 2,500 pharmacy locations that they're going to close across the United States. Yeah. And the stock for Walgreens is steadily going down. And look at Rite Aid out there, steadily going down. Yeah. So we're sitting here talking about prescription drugs. There is a problem out there in the pharmacy industry, in the chain sector, and also the independent sector as well. But when you start talking about healthcare in general, it's another major problem we had. And it's just like I told you a while ago, the patient should not have to choose about, or am I going to pay for groceries this week, or am I going to pay for my pharmaceutical drugs this week?
Sure. And
that's the whole thing. We've got to do something with this healthcare system that we have to help the beneficiaries.
Yeah. So, Robert, you of course represent the independent pharmacies, and those are different entities than the big corporate conglomerate chains. What's their approach to competing with those big guys? Do they are they able to acquire the drugs they sell, for example, at the same cost or close to that? How do they compete?
Well, service is number one. The independent pharmacies out there in the state of Mississippi and across the country, they can beat the chain pharmacies service hands down. It's unbelievable. And the patients, they will tell you that as well too.
Yeah.
A lot of times when you start, if you're a cash paying customer, you fall in that that void right there, that little area that you don't make enough to buy a commercial market insurance, and you're not eligible for Medicare, Medicaid, you're a cash paying customer. A lot of times the independent pharmacy will be the cheaper cash price. Now, when you start talking about the independent buying from their wholesaler versus the chain buying from their wholesaler, I would imagine the chain has a better buying power than the independent does.
Sure. Volume.
But exactly, it's just a volume-based business. But at the end of the day, the cash-paying patient out there, they'll get a better deal if they go to an independent pharmacy.
Okay. Well, so what's the overall health of the independent pharmacist in the state of Mississippi? How's the industry doing?
The industry's not doing good right now. The PBMs, the pharmacy benefit managers, basically have a stranglehold on these independent pharmacists out there, and these one-sided contracts. Like I was just telling you earlier, the independent pharmacists are filling a lot of prescriptions at below their cost, below their acquisition cost, and they're hoping they can make it up on some other service-oriented items, or they hope that they feel more prescriptions at a profit than they do at a loss.
Yeah.
We have to have meaningful PBM reform of some kind on the state level and the federal level. We've had a lot of congressional hearings on the federal level. Back in July was the last one. The three top executives for the big three PBMs were basically raked over the coals in a bipartisan support at a congressional hearing. Mississippi's own U.S. Senator Cindy Hyde-Smith is a big supporter of independent pharmacy out there and some type of PBM reform on the national level. She was very supportive of our efforts on the state level. Representative Jerry Turner and Representative Beth Waldo are having hearings concerning the PBMs select committee that was formed by Speaker Jason White.
Yeah.
There will be one Wednesday of this week. And such. But we have to look at meaningful PBM reform here in the state and on the national level so that these independent pharmacists and pharmacies can stay in these local communities and thrive and receive an adequate reimbursement so they can sit there and take care of their beneficiaries and the patients of that community.
Before we go, anything from a legislative perspective you're going to be working on this coming session, 25?
Well, we hope that, like I said, we hope to introduce some kind of legislation for PBM reform and transparency, but we're really working through the process right now with these this select committee on prescription drugs on the House side, and I know Senator Walter Michel has also looked into this a little bit as well, too.
Chairs insurance in the Senate.
Exactly. So we'll continue to move forward throughout this whole process and see where we are.
Yeah. It seems like something needs to be done. You know, I'm a free market guy. I don't want the government intervening in this, but something just doesn't seem quite right.
I agree with you 100% about I believe in the free market. But when the market gets so far out of whack, we've got to have the government come back in and help straighten the ship up somewhat.
Well, the way I see it, honestly, the justification for that is that it's the government that issues the patents to these drug companies. So if I'm going to issue a patent, well, then in return for that, you've got certain responsibilities and obligations, in my view. It's the way that should work.
You might have a point.
And, you know, a lot of times even the patent process gets schemed a little bit by these drug makers over time.
It does.
And that's causing costs. But I still say that one big continuous challenge we're going to have is the drug makers are very innovative. They're spending lots of monies on new drugs, new therapies,
R&D.
new cures, big time.
Every day. And
we benefit from that. You're familiar with this extremely expensive new, I think it's an immunotherapy treatment for sickle cell anemia. Extremely expensive. You want people who are sick with that to get this cure. I mean, if it could do it. I mean, I'm for that. But it is expensive, and it's a dilemma for the patient, for society in general.
It is, and you get to a point. It's just like the independent pharmacists out there right now. They are filling these prescriptions at a loss, but they are a true healthcare provider, and they're taking care of their patients.
Yeah, especially in the rural communities, right?
100%.
You're not going to have the big conglomerates typically locate in an area like that.
Yeah, and especially when you're looking at Walgreens shutting down 2,000, 2,500 pharmacies across this nation, you're looking at major problems.
Yeah, they're not going into they're not going to open up a new store in a sparsely populated area, but the pharmacists there live in that area.
100%.
And that's their interest. All right, appreciate it, Robert. Thanks for coming in, man.
Always good to see you.